So Dr. Biswas is a consultant geriatrician based in the Royal Glamorgan Hospital in Cwmtaf Health Board, and he has set up many services in his senior clinical management role, and he is clinical lead for strategy and planning for ageing well and dying well in Cwmtaf. Roger.
Thank you very much. Thank you for the introduction. And can everyone hear me? Yeah, that's good. Good start. So my name is Raja Biswas. I'm one of the clinicians, geriatricians based in Royal Glamorgan Hospital. And I'm not a scientist. I am more of an on-the-ground clinician. And I have been a geriatrician now for over 20 years. So I'm pretty old myself now, getting to that age, where I might need help of myself going forward. But one of the things which I would like to mention here, that I was very absolutely amazed at all the talks that I've heard so far and everything that is going on. And one of the things about my specialty is you might not need a cardiologist, you might not need a gynecologist, you will need me. You'll need me sometime in your life, hopefully. So starting with the health inequalities that we are going to talk about, how do you define health inequality overall? And this is the King's Fund definition, which some of you may be aware of, which is avoidable, unfair, and systemic differences in health between different groups of people. However, does health inequality is the same thing for elderly people as well? Because it should be more of a health inequity rather than a health inequality, because as you grow older and the differences which comes with age, you cannot expect the same kind of outcome in a 20, 40-year-old as in a 70, 75, 80-year-old. So there should be some degree of adjustment to the differences which happen between that age group. Well, some of the factors which are obviously involved are things like poverty and education, which are quite important in the health inequality which comes on. I'm not qualified to talk about that, so I'm not going to touch on them. But the other bits which I'm going to talk a bit about are things like access to service and treatment, ethnicity, and the effect of COVID on health inequality going forward. So there are inequalities across the country, we know that. So if you are born in Blackpool, you are likely to have a life expectancy of 74 years. While if you are born in Westminster, you are likely to live up to 85 years. That's quite a lot of difference in age in the life expectancy, depending on where you're born. In the 2021 census, which was done, there were about just over 10 million people over 65, which has increased by 52% from 1981 in 20 years. In Wales, in a few years' time, we are going to have about 30% of the population who are going to be over 65, not too long in the future. And number of people who are over 60 who are from a BME background, although that's not a term which is used very much nowadays, BME. There are various terms like race diversity, but for this talk, I'm just going to stick to BME, has increased by about 80% since 2011 census. So you are likely to see more people who are at above the age of 65 going forward who are coming from a BME background. And in England, there are about 2.5 times as many people from BME in their 40s as in the 60s, which does mean in the coming years, coming decades, you are likely to encounter more of people who have coming from a BME background. So one of the challenges which we are facing across the country, and especially also in Wales, and that we have a workforce which is very demoralized and demotivated. And I don't think I'm saying something which is out of the ordinary or surprising in this room. I have worked in the NHS for about 25 years now, and I have never been in a situation where I've seen my colleagues to be such a low morale from various factors. There has been lots of things going on due to work pressure, especially after COVID. There has been a huge waiting list. There has been a lack of support or funding, which the funding has gone on over the years. And there has been a number of industrial actions which are going on. Thankfully, one of the industrial actions has been resolved yesterday, So the consultant and the junior doctors resolution has happened yesterday, which is very good news for Wales. England has still not reached that stage, so something which they are behind Wales, and hopefully a few more things going forward. So that's one positive thing, but the healthcare worker are quite demotivated at the moment, and that is going to cause a lot of problem going forward for the elderly people. Why? Because elderly people need a MDT setting to look after them. And usually a geriatrician perhaps provide the leadership or the focus in that MDT group. In the Royal College of Physicians 2022-23 winter survey, there are about 13,000 patients, or about 10% of acute hospital beds, which were occupied by medically fit for discharge patients. So patients who were absolutely ready to go home but couldn't be discharged anywhere because there was nowhere for them to go. In my hospital, we have 2 wards which we didn't have, full of patients who are ready to go home but cannot be discharged anywhere. So that is the situation in most hospitals across the country. And much of this crisis is due to the health and social care needs which are not being met. So over the last, I would say, 10 years, 5 to 10 years, almost in Wales, there has been a closure of about 500 beds, care home beds. 500 care home beds which has closed down due to lack of money. It's no longer profitable. It's got more expensive to run a care home. Now, as a result, these patients who are ready to be discharged cannot be discharged anywhere and are stuck in the hospital. So keeping these patients in the hospital who could be discharged but cannot be discharged is very much harmful to them emotionally, psychologically, and physically. To be stuck in the hospital with no end in sight when they can go home, when they can be discharged, and to have that conversation every day, I find quite challenging in my everyday practice. At the moment, there are about 1,900 consultant geriatricians across UK according to 2021 RCP census. The national benchmark by the British Geriatric Society is about to have 1 geriatrician for about 500 patients over the age of 85 to offer a good service. Now, with planned retirement over the next few years, we need about 2,667 extra geriatricians by 2030 to provide that. That's very hugely challenging for 2 reasons. Firstly, the number of posts have been reduced by the government, and secondly, because a lot of trainees in geriatrics are less than full-time. So almost 37% of trainees are less than full-time, which makes it very challenging to have that many number of geriatricians looking after the elderly age group. There's also a lack of interest among medical students because it's not sexy enough, it's not interesting enough when they are in the medical college. When you want to be a cardiologist, you want to be a neurosurgeon, you don't want to look after old people. It's only when you come to face, you realize the challenges, the difficulties, how interesting it is. That's when you change your mind. There is a more of an interest in younger patients with diseases. So what kind of diseases they can treat. After all, Grey's Anatomy is a great advertisement for doing something like this. It is not practical life, but Grey's Anatomy has obviously encouraged lots of young people to go into medicine. There's a lack of status and financial reward as well, which is obviously important. The evidence base for treating elderly people is also a bit not up to the mark. For example, the drugs which we are using in elderly have not been properly evaluated by the European Medicines Agency. By that I mean, a lot of trials don't have elderly patients in the trials because they may be related to physicians who look at comorbidity or medication side effect or polypharmacy, so they don't want to put the elderly cohort into research. Or it may be by the pharmaceutical companies who are worried about unrelated side effect which can be resolved from the medication with nothing to do with their medication, but because of the elderly cohort there may be an unrelated side effect which can kill off the research completely. So millions spent on trying to introduce a medication might be completely put off the rail. So pharmaceutical companies are not very keen on getting elderly people onto the research things. As a result, often the treatment for elderly is extrapolated from the younger age group. So the best treatment and the most appropriate treatment is often not given to elderly people. So what's been the effect of COVID? Now, COVID has affected all of us, and however, the brunt of the effect of COVID has been borne by those over 65. About 80% of hospitalization were from the age over 65. And if you look at, compared to people who were under the 40, if you had COVID, you were more likely to die, 70 times more likely to die if you're over 80 years old, and 50 times more likely to die if you are about 70 to 79. I was in the front COVID ward from the very first day when COVID started, and I have seen the devastating effect of COVID on the elderly age group, and I'm still seeing them in my clinic, about the deconditioning which has happened as a result of the COVID, the social, the psychological, the emotional effect which it has happened, which often goes unreported because there has been no social contact for a long time. You have deteriorated to such an extent. I saw a lady the other day, she was saying that I was doing so well before the COVID, but now I had to stop going to the gym, I had to stop going to the swimming. And after, when everything opened, I can't walk now, I'm falling now, I need more help now, which I didn't need before that. These are kind of effect which has caused a lot of health inequality amongst the elderly age group. There has been an effect on the employment, something which often goes unreported. Till the pandemic, in the older age group, in the 50 to 64 age group, about 60% people were working in 2000, which went up to 73% in March 2020. But following the pandemic, the employment rate has dropped by 1.5%, and that's mainly to do with poor health being one of the main reasons for that drop. And about 40,000 more people retired in 2021 compared to 2 years earlier than that. And main reason again is due to the effect of the ill health and the lack of opportunities from a lot of companies due to working through Teams and Zoom, which has caused a lot of face-to-face jobs. The long-term effect of COVID has been borne disproportionately by older people. So things like cardiovascular diseases or respiratory diseases, neurodegenerative conditions, and functional decline as a result of that has been massive in older age group. And long COVID, which is something which a lot of people didn't believe in, but I believe in because I've seen the effect of long COVID, has been a lot of it has been in the older age groups, especially over 65. And they are at a much greater risk of suffering from long COVID after contracting COVID sometime during the last 3 to 4 years than the younger population. Ethnicity, especially amongst the older age group. So prior to the pandemic, the life expectancy was higher amongst the ethnic minority group than the white and mixed group. However, since then, it has not been the case. The Bangladeshi and the Pakistani communities have the poorest health outcome across a range of indicators amongst the BME population. And in England, there has been some data which has shown in the 61 to 70 age group, the Bangladeshi population, almost 86% of the Bangladeshi population have some kind of poor health outcomes compared to the white English group. And they do vary. For example, 86% of Bangladeshi, 69% of Pakistani background, 63% of the Indian background, and 67% of the Black Caribbean background. So the outcome is much worse in the BME population. And BME group also tends to have a lower life expectancy and even lower disability-free life expectancy than the white group as you go forward. Interestingly, I found this Indian women have similar life expectancy as the white British women, but 4.3 years less disability-free. A bit of good news, but obviously not as much as you would expect. So I'm sure most of you are familiar with the Marmot Review, which was undertaken in 2010. And some of the outcomes from that review was that people living in the poorest neighborhood in England will die earlier, about 7 years earlier, and live more with disability, about almost 17 more years than people living in the richest neighborhood. So obviously the economic conditions are a big factor into how you live your life. And the lower social and economic status equates with poor health. The health inequalities are reasons due to housing, income, education, social isolation, and disability. And it is preventable. The health inequalities are preventable, and they are preventable not only for a strong social justice case, but because there is a strong economic argument for preventing preventing health inequality. So annual cost of health inequality is almost between 36 billion to 40 billion, and that is often due to a loss of revenue, due to high taxes which you lost, or the high cost of service that has to be provided by the NHS. So action of health inequalities require action across the social determinants of health, which I had mentioned before, things like education, occupation, income, home, and community. So a much more varied focus has to be made to make any difference to that. This was in 2010, and 10 years on, there was a review of the Marmot to see if there has been any change. Unfortunately, there has been no change. In fact, increased life expectancy has slowed down since 2010, and there has been more deprived area. Now, UK has one of the lowest rate of life expectancy compared to other European countries or high-income countries, and inequality in life expectancy has increased since 2010. Do I have? Okay, I'll wrap up then. So, obviously, the amount of money which is being spent on the most deprived area has also increased. And because I have to wrap up, I'm not going to go on to the election task which has been by the British Geriatric Society for next Thursday. But some of the points here which are very relevant if we really want to prevent any health inequality in the elderly. These are 10 points which has been produced by the British Geriatric Society. I'll let you read it. But those are the points which are very, very relevant in stopping the health inequality. Thank you very much for giving me the opportunity. Thank you.
Thank you very much, Roger. As Roger has to leave, perhaps we have time for just one question to him. Does anybody have a burning question based on this talk? Perhaps you need a little bit of time to think about it. There's been a lot of very interesting content there. Okay, if there are no questions, perhaps maybe if a question comes up, they can write to you
absolutely.
And through Mina, and we will certainly continue to think very much about geriatrics.
Thank you.
Thank you very much.